Dr. Lim is a professor and chair of neurosurgery at Stanford. He is a rare breed of physician scientist that has not only achieved so much in the lab over the 15, 20 years that he's been doing his research, but also a phenomenal neurosurgeon that is not only caring for his patients, but really does amazing surgical work. I think it's always helpful to know if you were in a position of having a brain tumor diagnosis, who would you go see? And I get that question asked a lot. I had a personal friend who had a brain tumor, and the person that I called and asked to have him seen was Dr. Lim. So I think that's probably the highest praise that I can give, the person that a neuro-oncologist would reach out to and want to have their family or friends cared for. So please welcome Dr. Lim to the stage.
Well, thank you for that kind introduction, and I want to stress it's really an honor for us to be here. And I think every day and I tell our patients it's an honor to take care of you. And as Aaron mentioned, you let us into your lives, and we're here on your side, trying to, again, work on survival, work on making that quality of life better. And so, again, thank you for allowing us and giving us the privilege to be part of your lives. Before I talk, I also wanted to just give one more shout out to Aaron. I've known Aaron 20 years, and I'm so happy to see you get this award. Not only is she a brilliant clinician and an amazing neuro-oncologist, but if you think of Aaron, I think all of us would agree, she embodies selflessness, compassion, and kindness. And I've watched her take care of patients over the years, and she always says yes to everything, and she's got a mountain of work ahead of her. She's got emails coming in, pages coming in, but when she's with a patient, they're her entire world, and I think it's a special thing, and I think we're very lucky in this field to have you, but I just wanted to give one more kudos to you. So can we all give her a hand? Okay, so as I understand, we're running a little ahead, but it's kind of a rare thing. We're usually, at least if you're in our clinics, we're like an hour behind, right? But today I was going to talk to you a little bit about immunotherapies and what we call personalized therapies. To just start, these are my relevant disclosures because I have a lab. We do make discoveries, we have findings, and I do believe that working with industry helps speed progress, and so these are my relevant disclosures. When people come to me, I get a lot of emails all the time about saying, I want to go on to immunotherapy, and I have a brain tumor. And they want to make an appointment to see me. And as I've been working in immunotherapy for a long time, I tell people, immunotherapy is kind of like a relationship with your teenage kid. It's complicated. And there's yes and no answers to this. And so if someone comes to me and says, well, does immunotherapy work for brain tumors? I say to people, yes and no. And I'll go over that. So when we talk about immunotherapy today, most people are fixated on a class of drugs called checkpoint inhibitors. And checkpoint inhibitors, you may have heard the names ipilimumab, Opdivo, pembrolizumab. They call it anti-PD-1, anti-CTLA-4. That's really what I think most people in this world think about for immunotherapy. And there's actually more to that, but I'm going to focus on that in the beginning. In 2010, this paper came out, and it was a study published out of Dana-Farber for patients with melanoma. And in some ways, like most major scientific discoveries, this was a serendipitous finding. They were actually looking at this protein called GP100, and they believed that combining GP100 with this checkpoint inhibitor was going to provide better therapies for patients with melanoma. It turned out that the GP100, which they were very focused on, didn't matter. this other drug called CTLA-4 mattered. And even though on that curve, you can see a little bump in that curve, there were people that were essentially cured from their very aggressive tumor. And that opened the door in 2010 to a whole new revolution for cancer. And just to give you kind of a summary, I believe there's now 70 FDA-approved indications for these checkpoint inhibitors. And that's where I think a lot of people have become very excited and ask if this works for gliomas. This journey, I have, as a clinician scientist, I get the privilege of not only being in the lab, but I get to take care of patients. And when I finished my residency, I was actually at Hopkins for a while. And when I was at Hopkins, I saw some of these patients coming in, and Hopkins was one of the first sites with these that were testing these checkpoint inhibitors. And this is a drug called anti-PD-1. Now, checkpoint inhibitors, how do they work? People ask me. It turns out that when you have an immune cell, a T cell they call it, those are your soldiers in your bloodstream, they go and they kill things. If they see a bacteria, they'll kill it. If they see something foreign, they kill it. And actually, even in most of us, if you have small cancers that are brewing, they'll kill them. And what they do is they have a little receptor on them, and they identify the foreign or bad target to kill. But it turns out that God put a second switch on the T cells. So once a T cell binds its target, that switch either turns it on or turns the T cells off. And it's important because that switch prevents autoimmunity, prevents rheumatoid arthritis, Sjogren's. And cancers, and a good number of them actually found that switch to basically hide from the immune system. And the checkpoint inhibitors target that second switch. And when we started testing this, for example, is a picture of a patient with kidney cancer. You can see in those red dots these big tumors. And these big tumors were shrinking away at 4 to 5 months. Now, to give you an idea how powerful the immune system is, if you were to take a T cell, that's our immune cell, and put it next to a cancer cell, the T cell is 50 times smaller than a cancer cell. It's a true David and Goliath. And if you look at those tumors, they are big tumors. I mean, there are trillions upon trillions of cells and if you can think about these immune cells, they can come in, and it really is a testament to how powerful the immune system is. And so these patients were getting responses. And I just wanted to show this curve. They call this a spider plot. Each of those lines is the picture of a clinical course of a patient. And what they do is each of those dots is kind of the sum of all the tumors that are in that person's body. If the line goes down, that means the tumors are shrinking in those patients. And if you look, in the majority of those patients that were treated with these checkpoint inhibitors, those lines are going down. Their tumors are shrinking, and they're living 120 months, 140 months. They're doing really well. And so, of course, there's been a lot of excitement and a lot of hope for checkpoint inhibitors in patients with brain tumors. So I'm going to start with brain metastasis. Does this work for patients with brain metastasis? And the journey actually started after this study. What they did in patients with melanomas, they started combining the checkpoint inhibitors. There's really just 2 that are out right now. There's a third one that's just been approved, but the 2 called CTLA-4 and PD-1 were combined. And in these patients, when they combined it, these patients were doing well. This is another graph that I want to explain. Each of those lines are a patient. And if the line goes down, that means the tumors are shrinking in those patients. If the line goes up, the tumors are growing in those patients. And if you look in the middle, you can see that the median change was almost 52%. You can see that the vast majority of those patients had tumors that were shrinking away. And so with this therapy, a lot of people have been moving towards combination checkpoint inhibitors for patients with cancer. And after this study was published, we started asking questions as a group about whether or not patients with brain metastasis will respond. And this was a paper that was published by Dr. Margolin, and they tested people who had brain metastasis, in this case, melanoma metastases to the brain. And what they found in this study, it's an important study that was published in the New England Journal, is that about 55 to 60% of patients who had brain metastasis responded. In other words, the tumors started shrinking and disappearing in patients. So this was one of the first studies that showed that in patients with brain tumors, these checkpoint inhibitors could work. The caveat, though, to this is that almost 60% of the patients develop what they call grade 3 or 4 SAEs. SAE means serious adverse events, meaning patients needed to be hospitalized. And the complications from these medications is that it can actually induce autoimmune problems. You can develop what's called a colitis, or you could develop a pneumonitis, inflammation of your colon or lung or other organs. And in some cases, it's so severe that people have actually died from their complications. So this brought up a very interesting question because it's a very important question. If you remember from the tumor board yesterday we spoke about, you want to think not only about getting a radiographic response and survival, you want to think about quality of life. And if you're presented with something that says, well, you have a 60% chance of being hospitalized, you may need to pause. You probably need to pause and think about that. And that's why I say in this journey, you need to think about quality of life. These therapies that we give, you always have to ask, but what's the side effect? And so in this situation, the neurosurgeons and radiation doctors have other therapies where, for example, the biggest risk is what I call pseudoprogression. That's like a 10% risk. And this is a conversation that's being held in our field right now on how best to treat brain metastasis. But I can tell you now, they've seen this in melanoma, they've gone to lung cancer, they've gone to kidney cancer. A lot of these checkpoint inhibitors that work for the body do seem to work for the brain. And that's the bottom line for that. This is something called a swimmer's plot. And again, each of those lines are a patient. And they're showing, especially on the top half, that not only are these checkpoint inhibitors working to make the tumor shrink, but these patients are able to live a long time. You're able to extend survival for those patients. So that's encouraging because it seems to be working for brain metastasis. But what about gliomas? And we started asking this question, and as I mentioned, as a clinician scientist, I had the privilege of seeing one of the very first patients ever treated with the checkpoint inhibitors. And I remember he came to my clinic, he had a tumor up here, he had kidney cancer, and he was treated with anti-PD-1. We didn't even call it anti-PD-1 at the time, it was just called MDX-110. And there were a lot of patients at Hopkins on clinical trials. I always just said, we do standard of care for those patients. I took out that patient's tumor, and that tumor showed all inflammatory cells. There was no cancer. And over the ensuing 5 months, the guy, his lung tumor disappeared, his adrenal tumors disappeared. The guy was essentially cured. And because it was a new drug, at that time, I still made my patients come in every 3 months. And in about a year and a half in, he said to me, "Doc, do I need to keep coming back?" And I said, "Yeah, I mean, we have to keep checking." He goes, "I think I'm done." And I said, "Well, he goes, "I'm cured." And I just remember he sends me a postcard every year, and it just says, "I told you." And so, like 8 years into it, it still cracks me up. But that person was the one that inspired me to say, well, can we do this for our patients with gliomas? Because that's my main practice. And as the clinician scientist, this is what the ABTA supports. We're able to take that question and go back to the lab. And on the left here is a picture of a mouse experiment where Jing Zhang, she was a radiation resident who was interested in research, tried giving the anti-PD-1 to mice with gliomas. And in the middle line there, you see this bump out, which means that the animals were surviving longer. And so I was excited because this was what melanoma saw, this was what thyroid cancer saw, this was what renal cell cancer saw. In the animals, it seemed to be working. And then initially we went to companies like Bristol Myers Squibb and Merck to say, can we get this for our patients with gliomas? It seems to be working in the animals. And they said, not yet. They were a little bit worried. But then some case reports also came out showing that these kids with glioblastomas also had a response. So at this point, I was like, I'm all in on this. And this paper that I showed was published in 2012, so we started the journey in 2010. And if you see this publication is 2022, it took us 10 years to ask the question if this drug, this checkpoint inhibitor, works for patients with gliomas. We actually published 3 phase 3 clinical trials, 500 to 700 patients who gave their lives to help answer this question. And I have to tell you, this was one of those moments where I felt like I was punched in the gut. I thought it was going to work. In all 3 scenarios, the PD-1 did not work. The checkpoints did not work. And at that time, it was really hard to watch because we saw 40 other indications approved. Other cancers were working, but it didn't work in gliomas. And we've been trying other things. We've been trying vaccines, virus trials, and the big trials have been, thus far, negative. So, as I said before, for brain metastasis, it works, but the trials, at least the big trials and the definitive trials, say that anti-PD-1, at least the checkpoint alone, doesn't seem to work. However, we treated lots of patients, but we did see some patients responding. And this is a nuance. This is a case report out of WashU of a patient with a glioblastoma, and their tumor disappeared. And across the country, some of these patients were responding. And it turns out that this is where, when we talked about this in the tumor board yesterday, the pathologist, having a pathologist, a neuropathologist assessing your tissue is critical. When you assess the tissue of these specimens, what they do is they do all these molecular studies, and in this particular case, these patients that were responding had something called a high tumor, they call it high tumor mutational burden. They had lots of mutations. And as we've learned a lot in cancer, this actually started in lung cancer, this idea. It turns out that smokers do much better with checkpoint inhibitors than non-smokers for lung cancer. Why? Because with smoking, you create lots of damage to your lung tissue, you create lots of mutations in your DNA. And it turns out that we have genetic phenotypes that also can cause lots of mutations in our body. And this is a study for colon cancer, and this was a very big deal because they took patients with colon cancer, and when they had high tumor mutational burden, you can see the dark blue lines, those patients were responding. Almost 80% of patients that have this high tumor mutational burden will respond. And in fact, from this study, the FDA gave a very rare approval for an indication. Anybody with cancer that has high tumor mutational burden can get this drug. It was agnostic to type of tumor. It was anybody with that. And in fact, there are patients with glioblastomas and gliomas that have high tumor mutational burden. And again, this is the importance of going and getting a neuropathologist or having the tumor board review. And I can tell you, as an example, we had a patient that came in from out of state to evaluate. She was this young woman who had a grade 4 IDH mutant tumor. Those are still very aggressive tumors. The vorasidenib doesn't work for that. And she had gone under chemoradiation. She was desperate because she wanted to get other therapies. Those specimens came into us, and we did another reanalysis of the molecular studies for her, and she had high tumor mutational burden. And she got on PD-1, and she had a great response. So these are all examples of, again, while overall it doesn't work for the majority of patients, there are some patients with gliomas that do respond. The other category of immunotherapies that are, I think, having a lot of buzz is something called CAR T cells. Have you guys heard of those? Yeah. So remember, the T cells are the little soldiers in the bloodstream. It turns out that we've gotten pretty good at being able to manipulate them, and we can genetically change them so that, remember how I said the T cells bind to a foreign antigen, or they bind to cancer antigens. Well, we can engineer the T cells to bind to almost any antigen we want. And this is not a new technology. I mean, this has been around, I would say, 15 years. But this is what a CAR T cell looks like. It's a T cell there on the left, and then the box is around that receptor that's been engineered to then target the cancer cell. And over the past 15 years, we've created version 2, version 3, and you'll hear about that. But the point of it is that we've gotten good about understanding these T cells, and we can keep these T cells on constantly, is the bottom line of this, and they become more powerful. And what we've done is started to try them in patients with gliomas. This was a New England Journal case report that was published by Dr. Brown out of City of Hope. And this is a patient who had a very aggressive glioblastoma that went it was not only in the brain, but it went into the CSF and went all the way down to the spinal cord. And as you can see, there was a dramatic effect after the patient got the CAR T-cell therapy. Unfortunately, it wasn't durable. After a period of time, the tumors came back in this patient, but it gave us a glimpse of how powerful the immune system could be in the brain and the potentials for CAR therapy. This is a study that came out of Stanford, led by Michelle Monge and Crystal Mackel. And what they did was they did a CAR T-cell for patients with midline gliomas, not glioblastomas, but they call them midline gliomas. They are the tumors that arise mainly in the brainstem and the spinal cord for patients, as you know. And what they did was they found a target called GD2. They engineered a T-cell that targets this GD2 target. And what they did differently this time is they put in the surgery, after the patient gets surgery, they put a catheter into the brain. And do you remember how I talked about when you meet with the surgeon for the first time, in addition to getting diagnosis, in addition to trying to relieve mass effect, this is another important conversation to have with the surgeon, potential clinical trials. So these kids were given a catheter, an Ommaya catheter, and it allows us to inject the immune cells into the CSF of patients. This is the report of a young girl with a midline glioma. And this girl, if you saw videos of her, she was having contractures. She couldn't get out of bed. Her fingers were curled up. And it was a really sad case. And after she got an infusion, you could see her hands started opening up. And then her mom sent a picture of her riding a scooter. It was that dramatic. And then they started seeing other more dramatic cases. This is a picture of a person with a spinal cord midline glioma, and you can see it growing. You can see how big it is there on the left. And then at about day 90, it started shrinking away. The tumor started coming back. And what we learned was from the first phase, one infusion wasn't enough. And what they did was they moved to another part of the trial where they gave multiple infusions. And in this case, this was a 16-year-old with a very large tumor in the midline. And you could see after 4 months that child's tumor was essentially gone. And in this case, you can see another patient who had a spinal cord tumor. You can see it outlined in red, disappearing even after 9 months. And then this was another person after 6 infusions. Now this trial is being opened up to adults at Stanford, but again, we think that there's potentials for turning on the immune system. So unlike the checkpoint inhibitors, we think that, again, there may be potential roles for CAR T cells. And as an example, with this idea of local regional delivery, Crystal Mackel is really one of the leaders of CAR T cells. We have another trial going on right now for patients with recurrent gliomas with a different target called B7H3. And if you've been seeing the news lately in the past 18 months, several other centers have been publishing very interesting results. All of these papers are really only on 3 patients, though, so I want to caution you and say we should temper our enthusiasm. But there was a group out of Harvard at Mass General, Brian Choi, where they were able to create a CAR T cell that was very innovative. When the T cell binds to its antigen, it starts secreting another molecule that really excites the immune system around it. It's like a dual functioning one. The one in the middle is a study out of University of Pennsylvania, and they have a CAR T cell that has 2 antennas sticking out of it that targets 2 different receptors. And then with the third study on the right from the City of Hope, they've been really pushing ways of delivering the CAR T cells, and they deliver it into the CSF. These are all variations, but these are all iterations that are important. We're getting better, and we're thinking of new ways. In each of these cases, there have been some very dramatic results for people, at least in this situation for glioblastomas. So again, the CAR T cell story is a very interesting story, but it's developing. But if you notice, there's been no phase 3 trials, of course, to show that. Now, what I do want to caution you is while these films are remarkable, the patient's journey in getting these therapies are not easy. In some of those patients, with each infusion, they had to stay in the hospital 3 weeks. They were getting infusions every month. 3 out of 4 weeks, they were in the hospital because they were having side effects, fevers, chills, because you're essentially turning on the immune system. So again, it's an important quality of life. And for people who may not live in the area where these trials are, it's a significant burden to think about spending weeks in a hospital at a place to go back. And so, I mean, this is our job. We got to figure out how to make this more accessible to people, but also figure out how to make the safety profile better for our patients. But again, important conversation, important to have within your family and with yourself about quality of life versus change. After about 15 years of immunotherapy, this is kind of where we're at as a field. They call these hot and cold tumors. We've created these almost binary categories. And hot tumors, as you expect, are tumors that respond to immunotherapy. And on the right are cold tumors. It turns out glioblastoma is not the only tumors that didn't respond. Pancreatic and prostate cancer also are notable in the sense that they don't work with checkpoint inhibitors. And it really highlights the fact that the tumors interact with the immune system differently. The way I think about this is if you look at the tumors on the left, they are all based on organs that have exposure to the outside world, like skin, you get UV rays. With colon, you could eat toxic things. With the kidneys, they're excreting toxic chemicals. All those, the immune system probably interacts very differently and robustly with those organs, which is why I wonder if the checkpoint inhibitors work. These organs on the right are all pretty nestled away in the brain, and they probably interact with the immune system differently. And in fact, if we're asking these questions today, why? Why is it that these checkpoint inhibitors don't work? Should we be looking at other ways to turn on the immune system? And is it T cells? Is it there are other immune cells that are in the body? And it turns out there's another set of immune cells called myeloid cells or macrophages. And if you look at prostate, pancreatic, and gliomas, they're very rich in those cells. It's a different cell population than T cells, so maybe we need to be focusing on other cells. But the whole point is it's different, and we have spent a lot of time, I would say, trying to understand how the immune system interacts with gliomas in hopes of coming up with better therapies. And I can tell you, I mean, you'll see reports. I mean, we have a very exciting study combining PD-1 with LAG-3, and we're running that trial through the Alliance Network. It's a big NCI consortium. It's probably available in your area. And we think that that's targeting these other cells. But it's important that we keep taking shots on goal to be able to understand. If we don't take those shots, we'll not make advancements. All right, let's talk about targeted therapies. So with targeted therapies, it's this idea of, people even think of this as more like personalized medicine. Today, as we talk about targeted therapies, it's really about genetic mutations, okay? It turns out that in certain types of cancers, you can have a certain mutation that essentially drives the malignant potential of the tumor. It drives these tumors to divide. And these are some of the most famous driver mutations out there. And this was really pioneered in lung cancer and melanoma in particular. There's these genes, one's called EGFR, and it turns out that if you overstimulate EGFR in certain cancers, the cancers really like to grow. And if you can block it or stop that activity, the cancers will almost stop growing. And same with the ALK-ROS and BRAF. And in fact, if you look, this was a lung cancer study, and this was a drug against one of those genes called BRAF. And if you look, this is that waterfall plot again. Each of these are patients. And if the line goes down, that means the tumors are shrinking. Look at how dramatic most of those patients have had shrinkage of their tumors, their brain metastasis, if they got exposed to this medicine. And the top line is for patients who had never seen this drug, and their second is patients who have had other therapies. Even in more advanced cases, this driver mutation is very potent. In lung cancer, there's something called EGFR, and if you come up with an EGFR drug a drug against EGFR, again, those plots are dramatic. And in fact, when you patients with EGFR mutations, those patients have dramatic improvement in survivals. And again, this study shows that these drugs can get up to the brain. And then again, with the ALK-ROS mutation, these numbers are big. They're like 80%. Remember, I told you with immunotherapy, we're in the 50s. With these targeted therapies, 80 to 90% of patients will have shrinkage of their tumor. So what about gliomas? Do we have targeted therapies for gliomas? And the short answer is yes. One of the ones, I kind of classify this as a targeted one, is an exciting one that was been in the news in the past 18 months. It's targeting something called IDH. And you keep hearing us talk about IDH in tumor boards. IDH is a protein that's involved in metabolism. Just like you need to eat and then you make energy, IDH is part of that metabolism pathway. And if you can remember way back to high school biology, do you remember there was something called the Krebs cycle? It's like the circle, and there's like a whole bunch of these little genes that go in a circle. That gene makes 34, that cycle makes what they call 34 ATPs. That's our energy. It turns out that if gliomas have a mutation in that energy cycle gets disrupted. And that's how, but that's an Achilles heel for gliomas. And what they did was we targeted that. And this was a study, a company called Servier made a drug called vorasidenib. And when they treated these patients with gliomas that had the IDH mutants, you can see again those waterfall plots that are pretty dramatic. 45 to 50% of patients with grade 2 gliomas had responses. And this is a big deal because we hadn't had a therapy approved for gliomas in over 20 years. This was just approved. It doesn't work so well for grade 3s and grade 4s, and as we said, the grade 3 is a really tough conversation because we don't know about grade 3s. I mean, there's not always a consensus with grade 3s, but some of the more aggressive tumors don't seem to respond to that. But now there's a bunch of trials where they're combining with temozolomide and other agents to see if we can try to get the more aggressive ones to respond. But that's a big deal. And then it turns out that if patients have, for example, some of the same driver mutations as lung cancer and kidney cancers like BRAF, these are patients that have had very dramatic responses, which again highlights the fact that it's so important to have your tissue. You got to get your tissue to the people who are doing the tumor board because they test for this. It's not commonly done, but they should test for this. But gliomas being gliomas, and sometimes wanting to be stubborn, some of these therapies don't work, notably the EGFR. And if you look at this EGFR mutation, we've learned a lot. It turns out that in gliomas, they have a different spot that's mutated on their gene. And because it's a different spot, these drugs don't work. Also, they do what's something called amplification. They just make lots and lots of these receptors to promote growth. So it's not all the same, but it's complicated in the sense that some do work and some don't. So I've gone through this. With immunotherapy, we have brain metastases that respond. In general, gliomas don't. With targeted therapies, in general, if you have some of the classic driver mutations, these tumors respond. But, and we even have some novel targets. But I do want to make a comment about these driver mutation drugs. They are not just a pill like you take with vitamins. They're not easy to take. I can tell you, I mean, my mother had to go through the BRAF, and you have patients can have really significant side effects. They can have high blood pressure problems. They can have what they call hyperpyrexia. They develop these fevers. There's lots of issues that can affect people's quality of life with these drugs. They're not benign. I hope that by version 3 or 4, they'll be even more refined to decrease the side effects. But again, these are not benign drugs to take, and you have to think about that, again, as you go through this journey. So what's the future? I think I have a lot of hope for this because artificial intelligence and big data is here. And I think what's interesting is if you look at the changes that are happening in AI, it's happening every 2 months. It's not yearly, it's every 2 months. And we're hoping that we can use AI to help our patients with gliomas. As I mentioned before, when we start sequencing our tumors, we're doing it at single-cell levels. We're getting terabytes of information. It's not the kilobytes anymore. And we're going to be able to figure out how to personalize therapy. Now, this is the idea and the paradigm that we're trying to use in immunotherapy. The whole idea is to take the tumor, analyze it, in this case, sequence it. Once you sequence the tumor, we have a computer program that comes in and then starts looking through the sequences to say, these genes are probably going to be best targeted by the immune system. And then we can design vaccines around what the computer says is the best target for our patients. I can tell you that there have been several trials that have been run using this idea, and the results have been mixed. And the reason why they're mixed is there's, for example, 3 programs that are out there that can do this, what they call antigen prediction. And if you look at those 3 programs and compare what targets they all mention, only 30% of the targets overlapped. So there's a lot of fine-tuning that needs to be done. But I am optimistic that we will be able to create personalized therapies. We're pretty good at creating vaccines these days, and we're pretty good at, for example, creating CAR T cells. And I think we'll have a cocktail of CAR T cells as an example for our patients. And then I think as we do personalized medicine, this was a very interesting story on immunotherapy. It turned out that some of the researchers, when they're doing the experiments in mice, noticed that the mice had different responses to the same drug. And when they looked, they noticed that, for example, you can buy these mice from a lab in Maine, and there's another vendor in the Midwest. And they noticed consistently that the mice from Maine were always doing better and living longer than the mice getting immunotherapy from the Midwest. And they were the exact same genetic strain. And what they hypothesized was it's what's in the gut, is what they're eating. So some poor graduate student had to take the poop of the mice from Maine and put it into the mice from the Midwest, and took the poop from the Midwest mice and put them into the Maine mice. Yeah, that's all I have to say about that student. But when they did that, they changed the biome, and they flipped the survival curve. And it showed that what you ate could make a difference in how the immune system works. So as we move to personalized therapy, it'll also be how we affect our environment, or how we interact with our environment was a very big part of this. Since then, other people have done things such as stress. These poor mice were basically exposed to bright lights like this for hours and then not. But again, all these factors can affect how your immune system works. And it's interesting, when I was working with BMS for that trial, we had some patients who had really just almost burned through, their tumors were just growing at a crazy rate, even with the PD-1. And the first question they'd ask me is, are they a marathon runner? And it turns out marathon runners could also fare worse with immunotherapies. So there's a lot to this on how we interact with our environment. So in conclusion, immunotherapy, does it work? Yes, for certain types of tumors. More for patients with metastases, and a very small subset right now for patients with gliomas in terms of checkpoint inhibitors. CAR T cells, I think it's an exciting time, but the studies are on a very limited number of patients, and while we see some dramatic results on the MRI for these patients, I think we're going to have to go to bigger trials to really get you a definitive answer. I do think that we are slowly but surely making gains in immunotherapy for our patients. And right now, the immunotherapy, if someone asks me about immunotherapy, it's in the setting of trials for our patients, unless you have that hypermutation. With targeted therapies, they do seem to work for patients with brain metastases, with an exception of that EGFR. But again, I think, and what I also want to stress is that we have an exciting new therapy that was approved within the past year and a half, and we have options for patients with IDH mutant gliomas. But in both of these treatments, even if you enter into a clinical trial, it's important that you ask about the side effects, because these side effects are not trivial. And in this journey, quality of life is important. And as you go through this, as you think about survival and quality of life, at different points, one becomes more important than the other, and you have to make sure that's in alignment with your path. With that, I'd like to thank you for your time and happy to take any questions.
Thank you for that amazing talk. I think we're going to have plenty of questions. I'll go ahead and just start from the WOVA app. And just please remember, online users, to just click on the right session, which is the Transforming Brain Tumors with Personalized Medicine and Immunotherapy. The first question that they have here is, how is the research likely to be affected by the current climate of funding cuts and uncertainty, especially around the use of mRNA technologies? What can we do best to advocate?
That's a great question. I mean, I think it's across all fields that we are in jeopardy of having less resources for our research. And I mean, at a government level, right now, as I understand, we're in appropriations, and if we get what's called the continuing resolution, at least the funding levels will stay the same. In terms of certain things like the mRNA research, I think, and again, I may be wrong with this, the mRNA right now is really, the light is being shined on the mRNA that's currently being given as a vaccine, but I don't think that in terms of in the labs and in research, the mRNA is as much in jeopardy. And if we use that technology for our research, I think that it's still okay, is my understanding. But I mean, as I mentioned before, this is the problem with the NIH right now, is that the funding levels are the same. The amount of money they give for these different types of grants, Rs, Ks, has really been flat for many, many years. But the problems are that the costs of the experiments are going up. When I talk about single-cell sequencing, I mean, these are not $100 experiments anymore. These are thousands and thousands of dollars. And that's the limitation. The experiments are getting more expensive, yet the funding level is still the same. And this is where, again, partnership with the ABTA is so critical. And I have to say, working with industry is also very important. For example, when I was working with Bristol Myers Squibb, the first time I went to them with the model, with the preclinical experiment, that group of people said, no, absolutely not. We're worried about swelling in the brain. This is going to jeopardize our program. A year later, they had turnover in their leadership, and one of them, actually two of them, had personal friends that were affected by glioblastoma. And I remember going to them and saying, okay, can we consider the PD-1? I want to do a phase 1. And they said, no, we're going to go for phase 3. They went completely 180. But the people in industry, there are some really good people who are passionate about helping people with cancer. And it just takes repeated conversations. But I do also think industry is going to be important in this.
Any audience questions? While we're waiting, I'll ask another one from the app.
And I have a question too. If
Oh, yeah, please.
I'm supposed to be the microphone person, but
Yeah.
I'll lead it off. So, Dr. Lim, I remember from our own journey reading the pathology report, and we've talked about how important the genetic sequencing is. What do you mean for the lay people in the room by high mutational burden? Because it seems like all of these GBMs or high-grade gliomas do have, of course, mutations that come back on the path report. But which ones how many do you have to have, or which ones do you have to be considered someone who may be one of those cases that do show a response?
Yeah, great question. In fact, because it's an FDA-approved indication, as the pathology reports come out, they actually will say high tumor mutational burden, and they'll give a quantification of a number. And it is part of the standard readout for people who get next-generation sequencing. And so you don't have to interpret it yourself. It's actually one of those things that's, like they'll say MGMT methylated, they'll say TMB high. It'll come out.
We have a question over here in the front and then in the back. So I'll just ask one question here from the app. And this is someone who said that they have a family member doing well on a checkpoint immunotherapy drug in vorasidenib, a trial right now for patients who have a recurrent IDH mutant tumor. And they're doing well. Wondering how long does it take to see published results or data from a clinical trial such as this?
That's a great question. Well, first of all, it's almost, I want to say it's kind of milestone driven. And these trials are designed with statisticians to figure out how many patients are required to be able to tell if you can assess if there's a difference. Some trials accrue very quickly, and some trials accrue very slowly. In some situations, I've seen trials take 8 to 10 years to accrue the number of patients. And in other situations, I've seen trials accrue patients within a year. That's the first key step. And so when I ask, I think it's, as you're trying to figure out where the trial is, you could ask them, well, how long before you get the answer? And they'll say, well, maybe a couple of years. Or you could ask questions like, have they finished accrual? If they finished accrual, usually I say within a year you should have answers. But the nuance of that is finishing accrual means they've got all the patients, or you need to give time to wait. You should always ask those two questions to try to understand where they're at with the trial. Big trials, of course, might take a little longer.
Thank you. Right over here.
I have DMG, and I have sat in on conversations with nutritionists, and they're opposing information. So one says Mediterranean diet, one says don't eat salmon. So do you have a diet that you recommend? Because otherwise, with my diagnosis, I'm going to eat whatever the hell I want to eat. Like ice cream.
Well, first of all, I think you should eat whatever you want. I think that there's not a consensus right now on what people need to eat. It turns out that they're still trying to figure out it turns out that it's probably a certain bacteria population that make your immune system stronger or weaker. And they're still in the midst of trying to figure that out. What's interesting is this whole concept is called the gut-brain axis. And there was a really interesting study that came out. This is totally different than brain tumors, but there was an interesting study that came out of Europe where they looked at women who were pregnant, and they had to get really strong antibiotics during their pregnancy. And when they did that, that wiped out the gut flora of the moms and it altered the gut flora of the kids. And there was a high rate of autism in those kids after that. So there's this, the gut has tremendous connections with lots of parts of the body, but at this point in time, we don't know the answer on that. I think it's going to be certain bacteria, and I hope that that'll be a pill with just certain types of bacteria that you need to populate.
We had a question in the back. Okay.
First of all, I want to say thank you for your dedication and commitment to your field. This is amazing. And my question is, has there been any research done with respect to immunotherapy and meningiomas?
Yeah, it's a great question. So the short answer is yes. I know that, like the ABTA, there's basic research where they're able to take tumor specimens and really study the immune microenvironment to see how the immune system is interacting with the tumors. And I believe that there has been a meningioma checkpoint trial that was completed a couple years ago. I have not seen the results for that, but my understanding is that the results haven't been as positive as they hoped. But that's just hearsay, so I'm not going to say that's a definitive answer. But yes, absolutely, there's a lot of research going on for meningiomas.
If a tumor has shrunk somewhat from a checkpoint inhibitor, does that make it easier to remove? The question was remove in its entirety in a surgical procedure. So the idea is if you give someone a treatment and you get the tumor to get smaller, could we go back to our neurosurgery colleagues and say, could we do more surgery?
I would say that's a very nuanced question. I always say if it's a glioma, you could potentially go back to do surgery if it's going to improve quality of life, but I don't know if we know the answer on whether or not it'll extend survival for patients with getting a checkpoint inhibitor first and taking out the tumor. We are right now, as an example, trying to do what we call neoadjuvant trials. And it turned out that we learned a lot from lung cancer. In patients who have lung cancer, they actually give the checkpoint inhibitors before they go to surgery for about a month. And what's interesting is if you look at the blood of those patients, the T cell levels spike when you give them the checkpoint inhibitors before. They drop right before surgery, and because we think the T cells are going to the tumor. But there's a dramatic improvement in survival for patients who would get it in a neoadjuvant fashion. And and right now there's been some small studies. Dr. Clausey had a study out of UCLA where they gave the PD-1 before patients went to surgery in a recurrent setting, and there seems to be a signal there. And that's one of the paradigms that, not just in gliomas, but across many cancers that's being studied.
Hi there, thank you for your presentation. I wanted to ask, you kept tempering your results with the SAEs and the quality of life piece. I wonder, in your expertise, do you see a path forward with these research clinical trials kind of avenues where the therapy and the quality of life could happen hand in hand?
Yeah, I mean, as I said, for example, 60% of those patients who got the combination checkpoints for 60% of the melanoma brain met patients got the SAEs, but 40% did not, which means they had a pretty good quality of life. Some people do extraordinarily well. What I can also tell you is 10 years into this, we've gotten really good at managing the adverse events, and there's actually special sessions that are held about teaching people to manage those events. And I would venture to say maybe not 60% of people are coming to the hospital now. It keeps going down because we recognize the complications earlier. We can intervene with medications earlier before they get into that. But it's about learning about the therapies. But I can also say there are next generation checkpoints that are being developed, and hopefully what they call the adverse event profiles are better.
Hi. First of all, thank you for this. This is awesome. I have a question kind of back to nutrition for a second. The poop switching with the mice was fascinating.
Yeah.
And I'm just wondering if you can share any details about what those mice from Maine versus the mice from the Midwest were eating. I mean, were the Maine mice like having lobster? Like what? I mean, that's just really fascinating. And what we might glean from that.
Yeah, a great question. As I understand, I mean, if you buy food, the mice are fed these pellets, and if you look at it, it does not look appetizing. I mean, we see tons of them. But just like anything else in America, we have lots of different vendors that make pellets. And so it turns out the people from Maine bought their pellets from Purina, and the folks from the Midwest bought it from I don't know where else. But it's just different vendors. I mean, you would have thought maybe they would want to switch the food instead of the poop, but the poop was much more effective, apparently. Yeah? The quality of food. I mean, I'm not sure that they make organic mice food yet, but I think I'm sure that there's differences in what they contain. I mean, for those of us who have dogs, I mean, how many dog food commercials are out there? I have the pickiest dog in the world, so she doesn't eat any of it, but I mean, as I've gotten to know people, I mean, some people cook chicken for their dogs, and some people just give them, dry dog food. So,
One in the back.
Great talk, Mike. 2 questions. Any comment on NK cells and the therapies there, and anti-LAG3 to make the cold tumors hot?
yeah, great question. So NK cells are another group of immune cells that can kill. And they're a little bit more non-specific. Again, they complement the T cells, but they're known to be very effective in killing. And we've been able to now even create, they call them CAR NK T cells. And I think at this point, it's just, that's still in its infancy. And the clinical trials are up and running, but I have not seen as much results with that, which suggests that maybe we don't understand it yet, or I think it has to be in combination with T cells. The second comment on LAG3. LAG3 was approved 2 years ago by the FDA. That is actually the 3rd checkpoint inhibitor. And it's called anti-LAG3, and in melanoma, when you combine anti-LAG3 with anti-PD-1, patients did really well, like this combination therapy, but the toxicity profile is much better for those patients. And that's going back to your point, as we keep making new discoveries. So the LAG3 is something that's very exciting. I mean, from a personal standpoint, that is one of the main focuses of my lab. We looked at LAG3 years ago because we saw it expressed on almost all gliomas. And we have a LAG3 PD-1 trial that we ran through the NCI. And it's in a small number of patients, but we've had some very dramatic dramatic survival, or we saw some patients with very dramatic survival improvements. And we were then able to go back to the NCI, and we got approval to run it through something called the Alliance. There's 628 sites across the country. And we're now doing a large phase 2 trial on that. And so, I mean, I think almost anybody would be able to get access to that. It's in patients with first-time recurrent glioblastoma, but that trial is running right now. It's on a pause in the NIH right now because we have to do what's called a safety profile, but it's passed the safety profile, and I hope that it reopens next week.
Hey, Dr. Lin.
This is our last question, just so everyone knows.
Yeah, it's a great talk. I kind of follow-up question regarding the myeloid cells you just mentioned about. So is any kind of really kind of promising kind of drugs or kind of against or targeting myeloid cells really potentially kind of either single agent or in combination with the other agent can potentially can really bring a new kind of treatment options for glioma?
Yeah. Great question. So as I went back, it's going back to this. Remember I said in the tumor, there's the T cells, and then there's these things called myeloid cells. And these myeloid cells are these big blobby immune cells. And everyone says, well, we just got to activate them. But these cells are responsible for many different functions. They go and they do surveillance, they sample the environment, and if they find something abnormal, they teach the T cells. They're also responsible for helping for wound healing. They're also responsible for helping with vessel formation. And so it's the question of just activating them it's like a cell that has many, many functions. We were doing it imprecisely, not without any precision. And what we've been doing is now trying to drive those cells to do something like antigen presentation. And I think once we actually define what we want them to do, then we can actually ask the question of how we want to do immune cells. But those cells are very interesting because they're very critical for wound healing. And do you guys remember from high school biology, mitochondria? Remember, they're the powerhouse to the cells? It turns out that there's a whole new story coming out that they are the currency of cancers. And what they do, there was a very neat article where they showed these cancer cells, and these cancer cells had these spindles sticking out, much like a spider web. And what they do is when a T cell passes by, it can get snagged, just like a fly gets snagged in a spider web. And once they do, they're called tubules, nanotubules. They remodel and they poke themselves into the T cells. And you can see by video on this, they're sucking out the mitochondria from the T cells. They're literally sucking out the energy source to make the T cells weaker and only make themselves stronger. And it turns out that it's a whole currency. It turns out for wound healing, those myeloid cells actually can go to damaged tissue and they inject mitochondria into your damaged tissue to help you heal. So I think you'll see a lot about that because this is I call it the currency for energy in these processes. All right. Well, thank you.
Thank you so much, Dr. Lim. Let's give another round of applause for an amazing talk.
Wow. Thank you so much, Dr. Lim. You took a very complex topic and made it digestible to those who